Hi, I'm Stephenie Labandz. I'm a physical therapist. I currently work with the early intervention and early childhood special education teams with the Robbinsdale School District. I also have experience working with inpatient and outpatient neurological rehabilitation at North Memorial Medical Center, which is also a level 1 trauma center, so a very interesting variety of patients in that setting. I'd like to talk to you today about standing and cerebral palsy. Because standing can be a very effective way to address some of the challenges faced with mobility and overall health in clients with cerebral palsy. So as we move through the information today, our objectives are going to be to make sure that you are able to identify at least 5 of the common health or functional complications of cerebral palsy. You're going to be able to describe how standing minimizes the impact of at least 3 of the common complications of cerebral palsy, and you're going to be able to summarize the process for obtaining assistive technology for standing. So we'll talk a little bit about what CP is, and the National Institutes of Health define it as a group of disorders that can involve brain and nervous system functions such as movement, learning, hearing, seeing, and thinking. Pretty big umbrella term. Especially in rehabilitation, we like to break that down a little bit further, especially in the way that CP can affect motor functioning. So several different types that we can specify a little bit more, including dyskinetic, ataxic, hypotonic, mixed, and what we work with a lot, which affects function significantly, is spastic CP. So spastic CP involves muscles that are very tight, they're resistant to stretch, and they may tighten up even more over time. We'll get a little bit more into some of the reasons for that later in the presentation. Abnormal gait or walking is a significant side effect of the spasticity. And there's some characteristic gait patterns that do occur. We see scissoring of the legs, walking on the toes, arms tucked in very close to the sides, and walking up on tiptoes. CP is caused by injuries or abnormalities of the brain. The majority of these insults to the brain occur in utero as the baby is growing in the mother's womb. CP, because it is such a big umbrella term that captures a lot of brain injury or abnormality, can also include things that happen anytime during the first 2 years of life while the brain is still in some of that key developmental time. And we see a much higher incidence of cerebral palsy in children who are born prematurely. So a little bit more about when that CP happens. We have the 4 big Ps of cerebral palsy identified by some researchers. So there's prenatal, like we talked about, brain malformations that may happen in utero just with that development. Some children may experience a stroke in utero, which causes some damage to the brain that then materializes later as some of that motor cognitive impairment that we might see with cerebral palsy. And a mother who experiences a cytomegalovirus infection may also have a child who is affected. As I mentioned previously, premature birth and everything that can come with it, some of the hemorrhaging can certainly affect the brain and cause some of those CP symptoms that we see. Perinatally, right around the time of birth, children may experience hypoxic ischemic encephalopathy, which is just a really fancy way of saying the brain didn't get enough oxygen for whatever reason, and some damage was caused. There could also be a viral encephalitis, which could occur because of infection, other reasons, other illness, and then that's swelling of the brain, inflammation. Encephalitis that's what that means. So that can also cause some brain damage. Viral encephalitis and meningitis would cause that similar swelling of the brain, a similar physiological mechanism. And then postnatally, there can be further insults to the brain that could result in CP, accidental or unfortunately inflicted head trauma. Another anoxic insult, which again is any kind of episode that results in lack of oxygen to the brain. All right, I'm going to talk a little bit about the gross motor function classification system. It's very much based on function, which is in the name, and is just a way that many researchers have been able to establish differences between children with cerebral palsy because there is such a broad spectrum of effects that can happen and how it impacts function. So it's a 5-point scale. I'll talk about level 1. Which is the less affected end of the spectrum. Children who are classified at level 1 on the Gross Motor Functional Classification System, or GMFCS, are able to walk indoors and outdoors. They do not use assistive devices for mobility, and they are able to, for the most part, keep pace with same-age peers with some of those gross motor play and mobility activities, running, jumping, and doing some sporting things, although there may be some mild limitations in strength or coordination. Children classified at level 2 might be slightly more impaired. They're able to walk indoors and outdoors again, and usually do not use an assistive device, but uneven ground, ramps, crowded situations may require a little bit extra caution, a little bit of extra time just to be safe. Level 3, children are able to walk indoors or outdoors on level surfaces with an assistive device and move like classroom distances within a school building. These children may rely on wheelchair mobility when traveling longer distances or out in the community, or especially over more uneven terrain. Children at level 4, again, are going to be just a little bit less independent with their mobility. They may be able to still use a walker or gait trainer primarily for exercise, maybe walking around in a classroom, maybe playing in the gym, maybe doing some functional home skills, but their primary means of mobility is going to be relying on a wheelchair. They're going to need moderate to maximal assistance for a vast majority of their mobility. And then the children at level 5 are the most effective. Their physical impairment restricts their voluntary control of their bodies. They may have such significant weakness that they are heavily reliant on assistive technology for trunk and head support, and just grossly limited in their bodily functions, and pretty much maximal assistance for any mobility. The National Institutes of Health have noted some top complications that tend to be experienced with CP. These include common complications of CP, which include bone thinning or osteoporosis, bowel obstruction, hip dislocation and arthritis of the hip joint. They are more likely to sustain injuries from falls. Joint contractures are a significant issue. Pneumonia caused by aspiration is a significant cause of illness. Many individuals with CP have poor nutrition. Reduced communication skills may occur. Reduced intellect, depending on the significance of the brain injury or the location, is an occasional occurrence. Scoliosis is common. Seizures occur in about 50% of individuals with CP, and there is some social stigma that accompanies having a disability, and CP is also included in that. So that was your alphabetical list from the National Institutes of Health. I reorganized it a little bit more from a system standpoint. So we'll talk about kind of musculoskeletal, because that's the real meat of what most of us are really engaged in and concerned about in rehabilitation. But also we'll look at other systems and that great impact that they have on overall health and quality of life. So one of the big issues with CP is that bone thinning or osteoporosis, which occurs. And one of the reasons is that bone is built based on the forces placed upon it. So if individuals with CP are not bearing weight, if they're not doing high impact activities, every time they're not doing that, we're missing out on a chance to build and maintain bony tissue. Some of these individuals with CP, like I mentioned, maybe about half are experiencing seizures. Many seizure medications also detract from bone density. And I'm glad we kind of covered that whole big laundry list of symptoms because everything is very interconnected. With nutritional deficiencies, some of these children and individuals aren't able to have adequate oral intake of food, and depending on the timing of when that's really discovered, and maybe a feeding tube is placed, it's unfortunately very common that some key growth time has been missed out on. So we just want to be very aware that that doctors are monitoring the growth of individuals with CP and that they are receiving adequate nutrition. And then, of course, calcium and vitamin D, we all know those are excellent bone building vitamins. So we just want to make sure that, again, a growing child, an adult, anybody who has a mobility limiting impairment is receiving those nutrients so that they continue to maintain and maybe even build bony structure. So the great news is, with standing, children with cerebral palsy can experience fewer fractures. There was a research study done with 536 children over a period of about 15 years. So really looking at their longitudinal risk of fracturing. And we might not be surprised to learn that those children that were at those GMFCS levels, like 1 through 3, who were able to walk, who were able to bear weight on a more regular basis, experienced fractures at about the same rate as other typically developing children. But then when we look at those individuals who are less mobile, who aren't standing and walking with the same number of opportunities as same age peers, the risk of fracture increases several times. So being able to compare those non-walking children at GMFCS levels 4 and 5 and the children who were standing, those children who were standing regularly had a 4 times decreased risk of sustaining a fracture without trauma. And the really scary thing with some of these kids is, in most cases, I think it's about 80%, fractures happen without real trauma. It's not because they've fallen. It's not because of something that we would have, considered typical for causing an injury. It's really just going through a typical transfer and just getting dressed for the day. So that's how brittle those bones can become, and that's how essential it is to maintain that bone density. Now there are the children who do sustain injuries from falls, and in CP we can kind of think about why that might happen. Someone who does have impaired balance, someone who does have just less opportunity to be up and learning the limits of their balance, they may fall a little bit more. So they certainly can sustain injuries, bony injuries, or can strike their head or something because of that decreased balance. And again, we just end up with more fractures. So a typical kid might be able to fall and bounce back, whereas some of our children with CP who have some of these underlying issues are going to maybe fracture when a typically developing peer wouldn't. So one of the figures from this study showed us that children with CP sustain, as a population, between 7% and 9.7% of these children will sustain a fracture in a year. So that's a little bit worrisome that you may have almost a 1 in 10 chance of having a fracture just about any year if you do have a CP diagnosis. So how can standing help us decrease those injuries? Some standers end up being a really excellent, safe place to work on some of those dynamic balance skills. I've got my little friend Liam here in a sit-to-stand stander, and I've provided him nice, solid support at his feet and ankles. He's got his knees blocked, but I've allowed him a little bit of freedom at his hips and his trunk to do a little bit of that weight shift, to do a little bit of that forward and backward motion, to kind of try to find where those balance limits are. So if we can provide a fall-free environment to work on preventing some of those injuries, it can be an excellent tool to use standing for with support. And then we can also break down transfer skills. Many injuries are sustained in the course of transferring. And so just to be able to, once again, the way that I've got it configured for Liam, to be able to change that seat angle so that if he doesn't have quite the strength to do a sit to stand from 90 degrees hip knee angle, we can change that. We can give him a little bit more of a boost. He can work on the strength from maybe about 60 degrees to being fully upright. And then as that strength and coordination build, we can just decrease that angle, so maybe we do get to a full sit to stand motion, which could then be transferred over into a real life transfer situation. And again, supported standing helps to increase that bone mineral density, which would hopefully ideally decrease that risk of significant bony injury in the event that someone with CP falls. And it was found that more standing is even better, which is great news. In a population of children with CP, they worked on bumping up their standing time so that the children were doing up to 140.6% of their baseline standing program, and they were able to experience a significant improvement in their vertebral bone mineral density. Hip dislocation and arthritis are another musculoskeletal issue pretty commonly experienced by individuals with CP. And the reasons for this are multifaceted as well. One of the big contributors is abnormal muscle tone. So that spasticity, and the muscles that it typically affects are those muscles that pull the legs together, internally rotate them, and then place more pressure on the posterior and lateral aspects of the hip joint, which unfortunately that's also the location a hip is likely to dislocate into. And we can see again on this graph that the incidence of hip dislocation is going to be more significant in those individuals who are classified at GMFCS levels 4 and levels 5. The risk of dislocation is highest between the ages of 2 and 3. So that just really further shows us the importance of intervening early, especially because those bones are still developing, those growth plates still are open, everything is still very malleable. So if we can get things to grow in desirable alignment, it's going to make such an enormous longitudinal difference in the lives of these individuals. Again, just kind of showing what that hip dislocation looks like. We want to have a femoral head that is seated really firmly into that acetabulum so that we've just got that ball and socket working really nicely together. What happens in the kiddos with CP, if this is my right leg, it's getting pulled down and in, and then the head of that femur is riding on that edge of my hip socket, and we're not having effective movement, and you're having breakdown of the joint because things aren't just moving properly within it as they should. So standing is just really going to be an important way of hopefully mitigating some of the effects of that abnormal muscle tone and that positioning. And like I said before, the earlier we can get things into good alignment, the better the outcome can be. A large study in Sweden looked at really aggressively intervening with these children at an early age and having them stand, performing tenotomies of some of those really tight muscles that are pulling that hip out of joint, using selective dorsal rhizotomy or baclofen to really treat some of that spasticity at its core. And with that aggressive early intervention, the incidence of hip dislocation in those children was 1%. And on that previous slide, of those children at GMFCS level 5 whose hips were already at least a fair amount beyond where the socket, if they were on their way to dislocation or subluxing, about 47% of those children did dislocate their hips. So a 1% dislocation rate with that aggressive intervention is really significant. So with standing, we can help prevent some of the disability, surgery that might have to happen to realign bones or get joints back in place. And one of the big effects is just stretching out some of those commonly affected muscles and decreasing that spasticity that's pulling things into abnormal alignment. So with a population of children who stood for 40 minutes a day, that spasticity did decrease significantly, and the risk of dislocation also dropped. Another thing that children with CP experience is hypermobility of their joints. So I was talking about a lot of the individuals with high tone at first, but the hypermobility is also associated with those children who are affected by significantly low muscle tone. There's not that resting tone or the strength there to hold joints in place. And so with that low muscle tone, you also get joints that are a little bit more flexible than typical, and places those individuals at risk for some injuries as well. And then with the high tone, as we talked about with the hip dislocation, if you've got a muscle just sustaining a force on a joint and pushing on those ligaments, you can also end up with a hypermobile joint just because of that sustained pressure on the joint capsule and the ligaments that are just trying their best to hold that joint in good alignment. So with standing, these individuals with hypermobility are at least provided opportunities to activate their muscles with those joints in preferred, more appropriate anatomical alignment. We can support and affect the alignment of those joints and of that body so that we can maintain some of that normal amount of mobility and function. And in standing, the proprioceptive information, like where my body and my joints are in space, is affected in a standing position compared to other positions. So even just providing some of those people who have that extra mobility, sometimes they have a harder time of even knowing where their bodies are in space. So if we can just help activate those muscles, provide that brain-body feedback loop for them, they can maybe start to learn and experience some more improved motor planning around their loose joints as well. And spasticity, it comes up again and again. It's just such a core thing that we experience when we're trying to maximize function in our individuals with cerebral palsy. And it's just a disruption of that connection between the muscle and the brain, and higher spasticity, unfortunately, corresponds with decreased function, because your voluntary movement is not always voluntary. You've got muscles kind of running the show, overriding the brain at times. So fortunately with standing, we are able to decrease some of that spasticity. A group of children who stood on a tilt table for 30 minutes with 5 degrees of ankle dorsiflexion had measurable decrease in spasticity in the triceps surae and in the gastroc muscles. And those significant effects lasted for about 35 minutes after the conclusion of the treatment. So there is an effect, and it does have some lasting power. And this will come up again, I think, to the regularity of the standing program is also going to really, really relate to the amount of benefit, the amount of function that we can achieve with it. Joint contractures, these happen a lot, again related to some of that spasticity. And there are also some physiological issues that are being noted that are part of CP that play into this as well. But the big reasons are our bodies are very adaptable. If we are at rest, we tend to stay at rest. If we sit with our legs bent, our legs learn to just kind of want to stay bent. The position that your joints spend most of their time in is the position that they're going to want to stay in. So we need to make sure we're providing our bodies with lots of variety and lots of opportunities to move, because that's what these bodies would be doing if these children did not have the brain damage that they had related to their CP. They'd be up and moving with their normal peers, so we need to just make sure that we're providing opportunities for them to do that as well. That presence of that abnormal tone also does not help. Joints want to be flexed. And the tissue changes over time. Again, your body accommodates to whatever forces are or are not placed upon it. The cellular matrix in the muscle of someone with CP really does tend to be stiffer. And so if we allow that muscle to be stiff, it's over time, it's going to maintain that, and we're not going to have sarcomeres that are going to stretch as easily in response to forces placed upon them. So again, intervene early, and prevention is really going to be the best medicine in so many cases. Satellite cells are also essential in muscular growth and repair. And some of the science is showing us that children with CP also have fewer of these satellite cells that work in their systems. And I haven't done enough research to know if it's a chicken or an egg thing, if the CP leads to less of the satellite cells or the immobility really plays into the muscle just not proliferating as it would in someone typically developing. But I mean, this is happening at a very, very, very microscopic level. That the muscles of these children, they're just different from other kiddos. So we need to do everything we can to not let them be affected. So in standing, again, there we go, preventive. It's just an essential preventive health measure. It inhibits some of that abnormal tone so that we're not having muscles that are just driving the position of a limb. Of course, with standing, it's leg. Just making sure that we are providing lots of opportunities for bodies to be moving through what normal ranges of motion are. And standing is just such an excellent complement to the other interventions that we're commonly performing in response to some of joint contractures. So, Botox with serial casting. Maybe a little standing will also further enhance the benefits of that. Selective dorsal rhizotomy, it's a very common practice after a selective dorsal rhizotomy to be performing standing so that you're maintaining those excellent gains that were made by that surgical intervention. In the event that someone's being treated with baclofen to decrease their spasticity, or if they've already undergone a really invasive procedure like a tenotomy or a Z-plasty for an affected muscle, we just want to make sure that we're maintaining those gains that were made so that we don't have to do those procedures repeatedly. And once again, prevention, if you've got just an all-day positioning plan in place for an individual so that they are changing positions, they are experiencing movement, we can just kind of stay out of some of this trouble. Gait impairment is really common in cerebral palsy. Again, circling back to the frequency of some of that spasticity. Either we've got joints that have limited motion or we've got joints that have excessive motion that are making it a little bit more challenging to control the body. Often one side of the body will be affected more than the other. That certainly plays into one's ability to move and balance, and there's just some inherent incoordination between what is voluntary and what is involuntary movement. So all of those can certainly have a significant impact on one's ability to walk. So with standing, there's this great study that was done with children at gross motor function classification system levels 2 and 3. So these are kids that can walk. We're not just talking about those 4 and 5 level kids who are immobile a lot of the time. So standing for the kids who are ambulatory, it was found that even these kiddos experience significant improvements in their stride length, their gait speed, their stride time, their stance phase time, their double support time. Muscle tone was inhibited so that more voluntary movement was present, less involuntary movement was present, and they were able to achieve a little bit more dorsiflexion with each step. And with kids with CP, a lot of times they're plantar flexed or on their tippy toes a lot of the time. So anything that can just get them a little bit closer to heels flat or even toes flexing up a little bit with each step. It's just going to make that gait more safe, more functional, more energy efficient. So that's what standing can do for gait. Scoliosis is something that is frequently experienced with our individuals with cerebral palsy, and again, this is going to reflect probably back to some of those individuals more at that level 4 and 5 who do have less time to be mobile, fewer opportunities to use those muscles, particularly in the event of other joint issues. A subluxed hip is already going to put the pelvis in a different position, and then the spine, because we have such adaptable human bodies, is going to probably want to accommodate to just try to keep things in line as best it can with the forces that are in place. So then, of course, if we've got one side of the body more affected, that's going to affect the forces placed on the spine. And gravity. Gravity is always working on these bodies. And we need to just remember to do the best alignment that we can, again, as early as we can, so that we're maintaining good alignment for lifelong function. So the study looked at the incidence of scoliosis with a population of individuals with CP. And that green line shows our individuals who are at GMFCS level 5, and that little pinkish reddish one is level 4. So again, we're having, and what it's showing us is the angle of spinal lateral movement, lateral curve, the Cobb angle, the lateral curvature of the spine. Again, the greater the mobility impairment, the greater that risk of scoliosis and the greater the severity of it. So in the instance of some of that scoliosis, standing can help prevent some of the contractures and deformity just by putting that body into nice, supported, desirable anatomical alignment, and giving the body that experience of being in that position. Because like we were talking about before, being in that position against gravity activates some of those muscles that help to align the body in a more desirable position. Some of the individuals who are already experiencing significant scoliosis may be wearing a TLSO, a pretty significant plastic trunk brace, and that's great for preventing the progression of the scoliosis. But if we're not asking them to activate those muscles within that brace, they're not going to make really gains within their strength to prevent it from progressing any further. So I think just getting into standing with that great alignment and that TLSO is providing better posture can just really have a double whammy good effect. All right, so moving away from some of that musculoskeletal stuff, just kind of talk a little bit more about some of the general health issues faced in individuals with cerebral palsy. Poor nutrition is pretty significant for multiple reasons. Motor control is significantly affected by CP in many cases, and that can either be the fine motor control just for performing self-feeding, or there can be multiple issues that happen along the line between the mouth and the stomach, whether it's chewing, whether it's lip closure, whether it's safe swallowing. There's just so many things that tend to be challenging along the way that can affect one's ability to have adequate nutrition. And then vomiting and reflux are also very common in CP. So even if you're able to maybe get some good food into your system might say no thanks. So we just need to make sure that people are experiencing adequate intake to meet all their body's needs. Drooling is also a common occurrence. And once again, it has a lot to do with head position, jaw stability, the ability to close lips, and the ability to perform coordinated, spontaneous swallowing. And it has been found that up to 40% of children with CP between the ages of 7 and 14 have issues with drooling. And I've had mixed results with standing and positioning. Some kids when they're working hard, when they're excited, when they're really engaged, the drool comes out. And other kids, it's kind of the opposite effect. They sometimes just turning things on kind of helps cut it down a little bit. And we'll talk a little bit about just the effect that general positioning can have on some of that coordinated swallow in a moment. And then some researchers identified just a nice set of key questions and red flags that caregivers of individuals with CP should just kind of be aware of, just to nip some of these problems when possible. So if a child takes more than 30 minutes on a regular basis to intake a fairly age-appropriate amount of food, that's one thing to be maybe consulting with your health team about. If just getting that nutrition into a child's body is becoming very stressful for the family or for the child, that's something else to be really examining a little bit more closely. A lack of weight gain is a huge red flag that I think we all pretty much are being attuned to. And even if the child just fails to gain weight, we need to be paying attention to that, not just getting concerned when weight is actually lost, because I think that's already a little bit too late. And then a really, really essential one is just any signs of other ongoing respiratory issues. If you're feeling that a child is experiencing repetitive respiratory illnesses, there's just a little bit of that gurgle in the throat around meal times, that causes a lot of concern that some of the food might be going down the wrong pipe, which leads to a whole slew of other issues. As we've noted in other areas, those GMFCS levels 4 and 5 are accompanied with greater general motor control issues. So with those feeding and eating issues, we see that correlation between GMFCS levels 4 and 5 and greater issues with motor control. Oropharyngeal function is no exception. We see greater dysfunction with those higher GMFCS levels, accompanied by the subtypes that go along with that oropharyngeal function, like saliva control and managing food within the mouth. 85% of children with CP were found to have issues with oropharyngeal function. So this is something really noteworthy for us to be aware of, to be assessing or preventing whatever we can do. So withstanding an oropharyngeal function, there may be an increase in head control, or at least an ability to better support head position. And the best position for swallowing is going to be with the chin slightly tucked, neck flexed slightly, and reclined about 30 degrees. What that does, because the trachea is in front of the esophagus, so we've got the windpipe in the front, and we've got our tube down to the stomach in the back, that automatically lets gravity assist that swallowing function so that more, hopefully all, is going into the esophagus, and we're getting minimal risk of food items, anything that is not air, going into the lungs. If the issue is less about swallowing and more about actually eating, it has been found that standing can enhance fine motor control, and hand function improves with about 0 to 15 degrees of forward tilt. So we've got a cute little one right there enjoying a meal with her slight anterior tilt. Back to the reflux and vomiting that commonly occur, it is related to a significant number of factors. If individuals are sitting, they automatically have slightly compressed abdominal contents. That leaves less space for things to move around. It's very common that things aren't moving through the digestive tract as quickly as they would in typical peers, which leaves less space and opportunity for food to move in and through. And in standing, we automatically open up that rib cage and we open up that belly so that there is more space for the stomach to do its work and for the rest of the abdominal contents to keep food moving through. Gravity helps. Gravity's always working, like we talked about with scoliosis. We can have gravity be our friend. Gravity can help pull things down through that digestive system and decrease the amount that's able to come up. Reflux and vomiting in these individuals with CP is multifactorial, and it just relates to the whole massive effect that CP has on the digestive system. A lot of these individuals may be sitting for prolonged periods of time, are likely sitting for prolonged periods of time, which automatically decreases the space for abdominal contents. And there is just less gastric motility. And if things aren't moving along lower in the intestinal tract and we're still experiencing input of nutrients, things might start to come back up again. There's just a lack of coordination, again, as there is with some of that skeletal muscle that we're used to observing that is also happening internally. So with standing, there's more space for those intra-abdominal contents versus being seated in maybe not always a really perfect, wonderful posture. And gravity is assisting. Gravity is helping act on those contents of the intestines. Gravity is making more space for the contents in the stomach. And there has also been research done with diaphragmatic breathing and its ability to decrease reflux. So by taking some of those deep belly breaths and really depressing that diaphragm, my guess as to why that physiologically is helpful, as it has been shown to be, is probably that diaphragm is kind of massaging that esophagus, helping with that downward movement, and a much better place to try to work on that tall diaphragmatic breathing is in standing versus sitting. Moving along in the gastrointestinal system, bowel obstruction is a significant issue. Constipation happens in around 75% of individuals with CP, and I would venture a guess that is maybe even a little bit low as far as an estimate from what I see out and about with some of the patients that I work with. And again, the peristalsis, that squeeze and release of the smooth muscles in the intestines is affected, so things just aren't moving along quite as much as they should. And activity, just being active and moving, helps things move through the digestive system. If people aren't engaging in regular physical activity, that's missing out on an opportunity to keep everything moving. And some of these individuals don't have adequate nutritional intake. So if that system isn't being stimulated at an appropriate level, if not enough food is coming in, the body, again, accommodates and things slow down. With standing, muscles are activated to increase that intra-abdominal pressure, even if the peristalsis in the smooth muscle isn't working quite as much as it could. The external muscles of the trunk can activate in standing to put a little bit of pressure on and help things move a little bit more. Again, gravity helps to facilitate that down and out movement of intestinal contents. Incontinence is also an issue with our individuals with CP. The main reason for this is because the bladder can be affected by some of that abnormal muscle tone. So in the presence of a neurogenic bladder, the bladder is made to expand and contract and expand and contract. And in a neurogenic bladder, that bladder is just contracted most of the time. And 80% of individuals who underwent some diagnostic investigation were found to have those really hyperreflexive bladders. So that's a large percentage of the population, and that can really have an impact on just general day-to-day function. As far as being really symptomatic and being impactful on a person from day to day, that incidence is a little bit closer to 16.4%. In standing, we have, again, that gravity assistance. Even if the bladder isn't working to do a squeeze to get the contents out because it's already at its maximal squeeze point, we can have gravity help us to continue to flush out the system. Respiratory issues are very common in individuals with cerebral palsy. It has a lot to do with that lack of mobility that may be experienced particularly at levels 4 and 5 of the GMFCS. And if there is swallowing disorder in place, there may be aspiration of food or liquids that can infect the lungs and cause some significant illness. Standing, as we talked about with the reflux, it just leaves more space to expand that diaphragm. So if someone just has poor perfusion because of immobility, the air isn't getting all the way into those little tiny little alveoli in those lower corners of the lungs. When we're standing, we can create more space for the diaphragm to move. We can create more space for lung expansion. We can create more opportunities for some of that fluid to get moved, coughed out, and have it affect people less. In the event that the respiratory issue is really associated with that swallowing difficulty, we were able to see when we were talking about feeding and eating that there is just a lot of motor impairment that can happen in that oropharyngeal function. And as we talked about with having that little bit of a reclined position, we want to make sure that food is going down the esophagus in the back and not down that trachea toward the front of the throat. So again, just want to emphasize the importance of exploring that position if a child is deemed safe to be working on swallowing, but we want to optimize safety to put them in that slightly flexed neck, 30 degrees tilted back position, which can be achieved by standing. Some individuals with CP may have reduced communication skills. This is generally going to be related, again, to motor control. A lot of it comes back to motor control. We may not have adequate breath support to create enough sound to be heard. It could be just that the area of the brain affected by the CP is a speech center. And it could be that an individual is significantly impaired, that their cognitive skills just aren't at a level for meaningful communication. So with standing, individuals are placed in that wonderful position where we've got maximal opportunity for that diaphragm to move so we can get improved breath support. Utterances can be louder, utterances can be longer. Instead of a few words, we might get a sentence or two out, which makes conversation flow a whole lot better and is a great position to practice getting those longer, louder sounds out so that hopefully there can be carryover into whatever position an individual is in. People are at eye level with peers, which makes conversing, communicating a lot better and more meaningful. And if an individual is using augmentative communication, standing might be an ideal position for either improved head control or for fine motor control to utilize that technology. In some cases of cerebral palsy, there is reduced intellect, and it has to do with the location and the severity of the impairment to the brain. One of the great benefits of standing is it increases alertness. So even with our students, our individuals who do have decreased cognitive ability, decreased ability to interact, by getting them out of a lying down position, by getting them out of a seated position, by getting them upright, they're going to be more alert. They're going to be much more able to engage with the world around them and have more interactive experiences. And even with individuals in an intensive care unit, research has been done, especially with head injuries, which is also brain damage, which kind of can correlate back to our population with CP here. Even people who were minimally conscious because of the significance of their brain injuries, 87% of those individuals, when compared between lying and standing, 87% of those people did show more responsiveness to caregivers, more alertness, more reaction and reflex and response to the environment when they were placed in that supported upright position. Hearing and vision are also impacted, which has a great deal to do with the learning of some of these children. And again, it's motor. Your eyes have muscles that help them work. And a lot of our individuals with CP were preemies. The incidence of hearing impairment in extremely low birth weight children who are also likely to experience CP because of their prematurity, that's at about 13%. So that's something we really need to be aware of. With the motor impairment that can happen to the eye muscles, it's harder to fix the gaze on an object and focus clearly. So with standing, that child with a hearing impairment might be in a more opportune position for interaction, might be at more eye level, mouth level with peers, so it's going to be easier to maybe see lips or hear sounds that are occurring in the environment. And for some individuals, standing really cuts down on some of that abnormal reflex activity, which will make it a little bit easier to focus some of those very fine motor skills with vision and be a little bit more functional there. And having an angle adjustable tray really can help that individual with a vision impairment to put things at an angle that is a little bit easier to fix and focus on. Back to that seizure information where we learned early that the incidence of seizures can be about 50% in this CP population. It happens because the brain has been damaged, and standing is not going to prevent seizures. I can't give you that bit of good news, but it is going to counteract the side effects of some of the medications used to treat seizures, which can have a really detrimental impact on bone density. So once again, just trying to prevent any further loss of bone density, trying to prevent any preventable injury. And pain is a real thing for these individuals with CP. It has a lot to do probably with lack of position changes in some of the people with the more significant motor impairments. Spasms are painful. Spastic muscles are not comfortable. A group of adolescents with CP were surveyed, and 74% of those young people had experienced significant pain over the previous week. And it's broken down a little bit there. About 40% had pain in their legs, which I think we can understand. These are teenagers. They're probably sitting in classes and having limited opportunities to move around, accompanied with their CP. 34% of those individuals were experiencing headaches. Imagine being in high school and having a significant headache. A third of those kids are affected by that. Also trying to just reserve some energy because the CP takes so much energy, and then participate in their regular teenage lives. And 45% experienced pain during physical therapy, which I don't think is surprising to anyone, but we just need to be aware that that is occurring and making sure that we're doing what we can to prevent that. Sometimes standing prior to a PT session might increase some of that flexibility, cut down on some of that spasticity. So maybe that physical therapy time can be a little bit more pleasant for some of these individuals. And we need to really be aware of this pain because the children who reported more pain were also reporting more emotional difficulties, and there was also correlation with more impaired walking ability. So once again, if we get them standing, if we get them able to have more effective gait, if we just keep those bodies moving, hopefully they'll be a little bit more comfortable. And I think, I kind of talked about that standing. So we're maintaining their range of motion. We're providing position changes. We're just trying to provide them regular amounts of movement so that they're not experiencing that discomfort that's just related to pretty much those tight muscles and limited mobility opportunities. Unfortunately, for a lot of these individuals, there is some social stigma associated with CP. There have been some really wonderful and fascinating individuals with CP who have really come to the forefront and are just letting younger individuals know that they are accomplishing great things and they are changing the world with their CP. So just want to make sure we're aware of some of those great people and what they're doing. This is Abby Curran. She is Miss Iowa 2008, and since her win, she has been running a pageant for young girls with all kinds of developmental disabilities, CP, cognitive delays, and there is an HBO documentary that was done that just shows the impact that she is having on these children's lives and the confidence that they are experiencing. This is Stephen Wampler. He has a significant cerebral palsy that affects all 4 of his limbs and a lot of his function. But he is an avid outdoorsman, and he runs a camp for children with developmental disabilities. And he scaled the face of El Capitan over the course of several days with a lot of adapted equipment. But he is so dedicated to making sure that kids with disabilities are having these outdoor experiences through his Wampler Foundation. And I just can't underscore the value of having people in engineering and healthcare professions who know disability from the inside out. So Dr. Jan Brunnstrom Hernandez is a physician with CP, and her passion, of course, is helping children with CP. So just nice to know that there's so much more to what meets the eye. And this social stigma is based on multiple things. There's an assumption of intellectual impairment frequently for people who show significant physical disabilities, and we just need to blast that away. Sometimes the presence of conspicuous assistive technology, a communication device, a power chair, kind of creates this bubble around people that others might be hesitant to come into, which also then just limits our abilities to communicate with each other and understand each other a little bit better. Sometimes communication is limited, but with knowledgeable caregivers and assistive technology that's available, I just see this becoming less of and less of an issue all of the time. And that whole thing about being at eye level, if there are limited positions and limited opportunities to participate with people and just kind of be in the same space, it just limits opportunities. So once again, I just love the opportunities for people to be at eye level with peers and have that meaningful communication there. And caregivers have such a high value on individuals being able to be upright. So some of that standing technology can really have a high level of buy-in from caregivers because it is really seen as an important thing. And once again, if we can intervene early, if we can get caregivers excited about what can be accomplished by upright positioning, we'll just have better social functional health outcomes for these individuals with CP. So if you are interested in getting your hands on some assistive technology for standing, it is important to have a relationship with your local assistive technology professionals. There is so much that is available on a demonstration basis. And if you have any questions about how standing technology is funded, if you have any question about what payers might want to know about why you're choosing standing for a patient, this link will take you to an excellent resource for that information. So there are a few steps to the process, and the first one is that the therapist and or physician determine that the standing program is medically necessary. And we'll talk about medical necessity multiple times through the next couple of slides here, because that's what the insurance company wants to see. They want to see that there is a long-term benefit, that we are cutting down on future healthcare costs, and hopefully some of the evidence I've showed you leading up to this point can definitely back that up in your mind. All the information that I've shared with you backs up the medical necessity of standing for a wide variety of individuals with cerebral palsy. When you assess the patient that you are considering a standing program for, you're definitely going to want to know just general information about the individual, healthcare status, height, weight, diagnosis, and have some idea of prognosis as well. There is a worksheet for evaluations that was developed by the National Coalition for Assistive and Rehab Technology. That is a nice place to really solidify some of that background information. So we've decided that we want to stand, and then the rehab team has the responsibility to find the most appropriate standing device for the consumer. And the payer is also going to want to see that you've done your due diligence to make the best choice. Payers are going to want to know that you have selected the most effective device to meet the consumer needs, and looking at their bottom line, they want to know that this one is the most cost-effective choice as well. And this should be a team effort. There should be a lot of communication among everyone involved, the patient or caregivers for that patient if it's a younger person, the therapist who is helping coordinate this and helping choose some of this technology, the complex rehab technology specialist or assistive technology professional on the team, and sometimes, depending on the equipment that is being selected, there may be a representative from the manufacturer who can do some really specific education or troubleshooting if that's needed as well. A trial will be arranged for the selected equipment. In most cases I'm familiar with, the consumer has a week, if not a little bit more time, to try out the equipment in their real living environment, and that is so essential to really find out if there's a caregiver who needs to provide assistance, if that's a realistic thing for the caregiving team to be able to perform transfers, to operate the equipment, to make sure the equipment fits in the necessary areas of the home, and to make sure that it's functional and will benefit the individual. And there are frequently many different options and accessories to consider, and we want to make sure that the most appropriate accessories are chosen up front so that there's not a lot of troubleshooting that has to happen after the fact. And it's great, once again, if you've got that wonderful conversation going with the whole team to say, this isn't working, but I wonder if we try that other thing, just to have that chat happening, and sometimes maybe making that little bit of a change can make all the difference if you just are asking the right questions. This is a very, very, very basic example of a standing log. Many payers are going to ask now that data be collected over the course of that trial period to know that the standard was used on a regular basis, how much time was the standard used, what positions were used, whether a person tolerates being fully upright, if a partial position is most appropriate at this time, and then any kind of physiological, functional health changes that are noted. If that person who had a joint contracture has greater range of motion, that we want to note. If that individual who was having a lot of bowel and bladder issues is spending less time toileting and is able to spend more time in school, at work, and having, to take less medication to keep things moving, that is noteworthy. Step 3 is to gather the necessary documentation from the rehab team for product justification. So that is going to be collecting that log that was done during the trial and using some of that information to help further justify the medical necessity for the standing technology. And that letter is going to have all of that detailed information that was collected at the time of the assessment about the person's health history, any risks that they may be at for health impairment, or any significant health impairments they've experienced related to their immobility or their CP diagnosis. And it's really important, and I forget this myself, to establish your expertise in this area right at the beginning of the letter. Share with the payer your knowledge, your education, the number of years that you've been doing this. If you know a lot about neurology, you've got certification in knowing about neurology, share that information to inform the people reading your documentation that you do know what you are talking about, and you have been practicing, and you have seen the benefits of this technology over the long term. And this documentation must support the medical necessity for this equipment. I love to talk about the social aspects. I love to talk about those other benefits, but the payers want to know about the medical issues that you are preventing, helping with the use of the standing technology. After all that information is submitted, ideally, you get an approval, you wrote a really good letter, you made a really good point, you proved the medical necessity of the equipment. The delivery of the equipment will be scheduled with your local supplier and the consumer who is receiving it. In the event that the payer does deny payment for the standing technology, always, always, always appeal the decision. Ideally, they may give you some further questions, may want some further clarification. It could be as simple as that. Respond, be as helpful as you can, and just keep the conversation going, because we wouldn't go through the process of this trial and doing this justification if we didn't truly believe in the optimal health outcomes that can be achieved for this individual with the standing technology. Thank you very much.